Hello, everybody. Welcome to Chapter 37, Transport Operations, from the 11th edition of Emergency Care and Transportation of the Sick and Injured. This lecture really is going to focus on, of course, as the title describes to you, the different types of patient transport that we can utilize as EMS providers. Also, the situations in which we might have to utilize these different types of transport. We're going to focus on two, primarily ground and air. And not only what type of situations we might find ourselves in to utilize air versus ground or ground versus air, but what types of patients also warrant the use of an air evacuation or air ambulance as opposed to going on the ground with an ambulance. So we're going to skip ahead a couple of slides through the introduction and get right to it. All right, emergency vehicle design. An ambulance is a vehicle that is used for treating and transporting patients who need emergency medical care to a hospital. Today's ambulance designs are based on NFPA 1917, Standard for Automotive Ambulances. Enlarged patient compartments as opposed to a fire engine. Fire engine, of course, sits usually 4 or 5 people in the back, 2 in the front. But it doesn't really have room for a patient. We can't really transport a patient. And of course, by law, we know that to transport a patient safely, legally, they have to be strapped by seatbelts to the gurney. And the gurney has to be able to attach or lock itself into the floor of the patient compartment. And of course, like in a fire engine you see in this picture, there is no room for a patient compartment. So that's what makes ambulances special. Sometimes you'll hear ambulances referred to as rescues. So when a fire crew gets on scene and they assess the patient or extricate a patient and they radio dispatch and tell them we need to get a rescue or an ambulance, they're calling for some sort of vehicle that can that has a patient compartment large enough to fit a gurney that locks into the floor of the ambulance so that they can transport them from the scene to the hospital or whatever the destination is. First responder vehicles have personnel and equipment to treat patients until an ambulance can arrive. Of course, they're talking about fire departments. They carry a lot of equipment that we don't. Circle saws, chainsaws, they carry axes, they have turnout gear like you see this firefighter wearing in the picture, helmets, special gloves, puncture-resistant gloves, boots, and so on and so forth. A lot of equipment that we don't carry on the ambulance because we're not trained specifically to handle those types of situations like vehicle extrications or water rescues or tactical rescues and stuff like that. Private ambulance, we don't really deal with that. We're not trained with that. So these different types of first responders or specialty responders are going to come and assist us in the sense that they provide a specialty service and we provide largely the medical care and the transportation of the patient. Components of the modern ambulance: we have the driver's compartment, the patient compartment big enough for 2 EMTs or 2 paramedics or an EMT and a paramedic, and 2 supine patients. Technically we can transport 2 patients at a time. And because we can transport 2 patients at a time, that will define the meaning of an MCI, a mass casualty incident, which we'll talk about in the next lecture, Chapter 38. MCIs, the best way to define one is any situation, any number of patients that outnumbers your immediate resources. So the book defines an MCI as 3 or more patients. And that, of course, fits in with the definition of an MCI being anything that outnumbers your immediate resources. Your immediate resources being you and your partner, the ambulance that can carry 2 patients. So 3 or more would outnumber your resources. Equipment and supplies, two-way radio communication, and designed for maximum safety and comfort. Here you see the basic ambulance design. This would be pretty good to know. Also, it's kind of fun knowledge to have when you're driving around and you see an ambulance. You can use this knowledge to identify what kind of ambulance it is and what kind of ambulances different companies are using or purchasing. So the Type 1 is the conventional truck cab chassis with a modular ambulance body that can be transferred to a newer chassis as needed. We have the standard van with forward control integral cab body ambulance, and the Type 3, the specialty van cab with a modular ambulance body that is mounted on a cutaway van chassis. Okay. Emergency vehicle design. Ambulance licensing or certification standards are established by the state, so it varies from state to state. The Star of Life emblem that is affixed to the sides, rear, and the roof of the ambulance. This, of course, identifies the ambulance as an emergency vehicle. All 6 of these points on the star stand for something different, and I would encourage you to look those up. It's kind of cool to know. But, of course, legally, a vehicle cannot have the Star of Life unless it is licensed by the state, adhering to the certification standards of the state to run emergency calls, to transport patients, to be used for medical purposes. Here you see the different types of ambulances that they just mentioned. Of course, on every single one, you can see the Star of Life. Okay, which of course denotes or indicates that these are emergency vehicles. You can see the Type 1, the Type 2, and the Type 3. The van-looking ambulance you see with a bunch of companies now, especially in Arizona with AMR moving in. AMR is starting to use those ambulances that you see on the bottom with the front of the van, front that looks like a van, and then the box truck in the back. Some of them are starting to look like trucks in the front as well. Of course, that's an older style ambulance on the bottom there. On the top left-hand corner of your screen, you can see the truck front with a box truck in the back, and there's a clear separation between the truck front and the box truck in the back. So there's actual physical barrier, a separation between the driver compartment and the patient compartment in the back. And in the top right hand corner you can see the van, which which AMR likes to use as their ambulance, especially for GT or general transport or interfacility transports. We nickname them the Vanbulance. That's the one that I was on for a while, and I enjoyed it. I ran some calls and did some shifts on the box trucks, which was fun, but a lot of people don't like the Vanbulance. I didn't mind it so much. The big argument is that there's less room in the back of a Vanbulance as opposed to these box trucks, which is true, but you kind of have to make do with what you're given, and if you are a smaller person, it doesn't matter so much, and you'd be able to fit comfortably. Other than that, I didn't really see a problem with them. So the phases of an ambulance call, you see them all listed out right now. We're going to go through them one by one in this lecture here coming up. So preparation phase is, of course, the first phase. Here we make sure equipment and supplies are used in their proper place and ready for use. This preparation phase is probably the most important phase of the entire day, of the entire transport or shift or whatever you want to call it. Preparation is incredibly important. So as soon as we get on shift, one of the things we're going to do is, if you're working on a double EMT or double medic or EMT and paramedic truck, it doesn't matter. This is going to go down the same way. So if you are on a, let's say you're on a EMT and paramedic truck, like most likely you will be in Arizona, in Arizona. The EMT, of course, really has the responsibility of driving the vehicle most of the time. We know that legally the paramedic has to be in the back as the primary patient caregiver, legally has to stay with the patient at all times. So usually during transport phase or during responding phase, the EMT is going to be largely responsible for the truck, which is a big responsibility. So usually in the preparation phase, the EMT is going to check off the truck, which means checking the tire pressure, checking the oil levels, fuel levels, making sure that the lights and sirens work, making sure that all the different functional components of the ambulance are in working order so that it's safe to use the vehicle for the rest of the day, which is a huge responsibility. While the paramedic, who is largely in charge of patient care, is going to be going over protocols, is going to be making sure that all of the medical supplies that we're going to be using for any given patient is stocked, making sure that the drug box has the proper amount of medications, that they're within their expiration date, that all the narcotics are there if we do need them, and really just making sure from both ends that the truck, the equipment, and the medical supplies, what we're going to be using to treat the patient, is in working order or functional capacity to be able to start the day. And these aren't predetermined by you, these are predetermined by the company and what they call PAR levels. And PAR levels are specifically listed out that you should have so many of 20 gauge IVs, you should have so many of 18 gauge IVs, so many IV bags, so many gauze pads, all that kind of stuff is already laid out for us. So we're really just checking to make sure that we have enough and that it's usable within its expiration date. And then we should be ready to run calls. We're going to store equipment and supplies according to how urgently and how often they are used. Of course, supplies as a paramedic that I need to use constantly are going to be within reaching distance. They're going to be towards the front of the cabinets where I can see them easily. That way I don't have to go looking for them, or I don't have to guess at where they are. And it really helps if the cabinets are clear. Either the cabinets should be labeled with everything that's within that particular cabinet, or they should be clear, see-through, so that you can look through the doors of the cabinet and know exactly what's in there, so we don't waste time trying to fish around or look for different types of equipment and really delay patient care, or in my professional opinion, make us look like fools because we don't know what we're doing. We're not well acquainted enough with our ambulance, and of course that doesn't look professional no matter what business you're in, no matter what job you have. Just like I said, the cabinets here, you can see both labeled and the clear doors in front, so you can see exactly what's going on and what is stored in that cabinet. Okay, they should open easily and close securely. Of course, you want them to close securely so that if you make a hard right turn, all that stuff doesn't come flying out of the hard right or left turn, that all that stuff doesn't come flying out of the cabinets and spill all over the place, and God forbid your patient as well. Medical equipment, we have basic supplies, airway and ventilation equipment. A lot of it you're already familiar with at this point: the nasal cannula, non-rebreather, BVM, the suction unit, you can see. So we want to make sure not only that we have that stuff, but that it's in working order. Of course, that we have good batteries for the suction unit. We're going to test that out, make sure we have good suction, make sure that it's clean, make sure that we have a new canister, new tubing, new suction catheter. And we have the bottom picture there, you see CPR equipment like a short board that we can put under the patient, a CPR board. That gives us a hard flat surface underneath the chest so that we can do compressions no matter really where we are. We can slide this under a patient that's laying on their bed. If you didn't move them to the floor, to that nice hard flat surface, you can put something like this underneath them, and that will aid in the effectiveness of your chest compressions. And of course, we have basic wound care supplies like roller gauze, bandages, band-aids. We have splinting device, splinting equipment, and so on and so forth. Like I mentioned, splinting supplies you can see in that upper right-hand picture there. We have childbirth supplies like the OB kit. Inside of the OB kit, like you can see at the bottom there, you can see the gauze pads, you can see the umbilical clamps, you can see chuck pads that we put underneath the female who is giving birth to kind of prevent a spillage of fluids. We have the bulb suction catheter that we use for the infant to suction the mouth and nose. So all of that supplies should be on the ambulance. We're going to make sure that we have that supplies. Even the non-disposable supplies, the stuff that we don't throw away, we want to make sure that we have it ready to go at the beginning of the shift, so that if we do run one of these calls, we don't get caught empty-handed, so to speak, in that we weren't prepared and we didn't have this equipment ready to go. We have patient transfer equipment, like you see the gurney in the top picture there. Of course, that's integral to actually not only moving a patient from point A to point B, maybe that can't walk or has spinal injury, but also for, of course, transporting the patient. The only way that we can legally is secured to the gurney, like you see, and then eventually the gurney will be secured to the floor of the ambulance. I do want to touch on the jump kit very quickly. Registry, I've seen a lot of questions come from registry about the jump kit, just in the sense that they want you to know what it is. So the jump kit is something that we carry on the ambulance that is loaded up with supplies and serves the purpose of having everything that we might need in the first 5 minutes of the call to run that call without having to go back and forth to and from the ambulance. So that jump kit, a lot of the times depending on what company you work for at AMR, we had a adult jump kit and a pediatric jump kit. So we had a bunch of pediatric specific supplies in one bag, and we had adult specific supplies in one bag. And again, the purpose of the jump kit is to hold a bunch of equipment that we might need for the first 5 minutes of a call, just enough to start some initial care on the scene and then get them on the gurney in the ambulance where we can continue our care en route to the hospital. Safety and operations equipment, we might have personal safety equipment for firefighters. Usually they'll carry stuff like road flares and traffic signs, warning signs. But on every emergency vehicle, we are required to have those reflective safety vests. So anytime we're out on the road, anytime we're in an intersection, running a call on a highway, and there's cars going by, of course we have to wear those safety vests to give vehicle operators a better chance of seeing us, reducing the risk of hazards potentially in relation to getting hit by a car or accidents or vehicles not paying attention, right? It kind of draws attention to ourselves. Okay. Pre-planning and navigation equipment, we have the MDTs, which are the mobile dispatch terminals. If you've ever seen the inside of a police squad car, you will see you will see the laptop that's there in the passenger seat that they use to run license plates and driver's license and search for warrants and stuff like that. We have computers that are similar to that, and all of our dispatch information comes to the computer. We have GPS on the computer, and we can easily navigate our way to the call. What it used to be was just a binder full of maps and area codes and all that kind of stuff, kind of archaic. So we're kind of moving into the new technological revolution that we've had in the past 20 or so years, and outfitting ambulances and fire engines and squad cars with these MDTs where all of that information is easily accessible. Personnel, at least one EMT in the patient compartment during transport. So that means that somebody, of course, has to be the primary caregiver with the patient at all times. If you are the same level of certification, it does not matter how much experience you have over the other person. Either one can be the primary patient caregiver in the back, filling out the chart, conducting the assessment, doing the interventions, and the other person, of course, has to drive the ambulance. If you are EMT and paramedic, of course, you are not the same level of certification, so the higher level of certification always has to be with the patient legally. And of course, the same rules for if you're running double medic, same level of certification, anybody can be in the back. Now, generally, the person with the most experience will take the primary patient caregiver, but legally, nothing says that that has to happen. So I ran double medic with this gentleman one time who had been a paramedic for only a couple of months up until that point. And we had a conversation at the beginning of the shift, and he said, yeah, I'd like to get some more experience with some IVs. I'd like to get some more experience with charting and kind of just have you as a safety net sort of thing, just kind of watching and listening. So I got to play EMT for the day, and I was pretty psyched about that. I haven't got to do that very often, but I like operating the ambulance. I like driving code 3, doing the lights and sirens. It's a lot of fun. So in any case, if you're an EMT riding with a medic, you kind of have no choice. Paramedic must be in the back. But if you're running double EMT, you can of course be in the back as the primary patient caregiver. Perform your daily inspections like we talked about. We want to make sure that the ambulance is checked off. We want to make sure that everything is in place. We have adequate numbers of medical supplies, which secures our ability to run calls at least for a portion of the day. That doesn't mean that those supplies are going to last you for the entire shift. If they don't, if you run out of a certain supplies that you're going to need, it's a very easy fix. After the call, you're going to radio dispatch, and you're going to let them know we need to return to the station for restock, where a lot of those commonly used medical supplies are going to be housed at the station, kept at the station, and you can return to the station, get the supplies that you need, and quickly go back on shift. We're going to review safety precautions, review traffic safety rules and regulations. Okay, we want to make sure that when we're operating the ambulance that we are not doing so in an aggressive manner, that we are not doing so in any way to damage property or persons. That's called driving or acting with due regard. We want to make sure that we are doing our job in a professional manner. We want to make sure that we are not breaking the law. There are specific laws for emergency vehicles, so you shouldn't go into it thinking that code 3 means you can break all the rules and do whatever you want and drive wherever you want. So we want to make sure that we are reviewing the laws of the land and that we are operating in compliance of state law, vehicle operating law. Ensure safety devices are in working order. Okay, that means lights and sirens. We want to make sure that those are working. Properly secure the oxygen tanks. You don't want one of those big M tanks rolling around while you're transporting. You don't even want one of the small D tanks rolling around while you're transporting, so you want to make sure that those are secure before driving. Properly secure all equipment in the cab, rear, and compartments. Now we're going to talk about the dispatch phase. Dispatch must be easy to access and in service 24 hours a day, so you should be able to reach them at any time. And it should be easy enough access for anybody with any type of emergency call to be able to call in, report that emergency, and have the appropriate resources respond. That's why we have the 911 phone system. The 911 is easy to dial, it's easy to remember. Everybody knows what 911 means. And when you call that, you will immediately get in touch with dispatch, day or night. This is so easy to access. Even on smartphones now, most of them are password protected or passcode protected, but now you don't even need that to get to a page that will allow you to dial emergency response from really just about virtually any phone that you can come in contact with. May be operated by the local EMS or by a shared service. May serve only one jurisdiction or may be an area or regional center. A good example of this is AMR Maricopa. When it was first starting out, when I was first hired, they were so new we didn't have a dispatch center set up. So our dispatch was actually run by the dispatchers up in Lifeline, up in the Prescott area, and they were running our dispatch, our 911 calls and dispatching us from Prescott while we were operating down in the valley. And of course now they've expanded to the point where they have their own dispatch in Maricopa, but that's a good example of a shared or mutual aid dispatch center. The dispatcher should gather and record the nature of the call, the name, present location, and the callback number of the person that called. This is really important because sometimes we do show up on scene and there's no one there. We don't have a patient, we don't find anybody, so instead of just giving up and going back to the station, we're going to do our best to use that information, the person's name, patient's name, the callback number that they gave us to try to reach the patient. And sometimes we don't have any correspondence with anybody once we arrive on scene, so that means that we would have to fill out a PCR cancellation because the patient wasn't found on scene, and it's as simple as that. We want to know the location of the patient for obvious reasons. This is incredibly important because we want to be able to find our patients, the number of patients, and the severity of their conditions. This might not be determined by dispatch. They're going to try to get, of course, if it's a larger scale event like a fire or explosion or something like that, any sort of natural disaster, try to get an initial head count, but of course you can't expect the caller to really any bystander to be able to gather and give you that information. So a lot of the times that's going to be handled by the first unit that gets on scene. We're going to get the number of patients, and if there are more patients than we can handle, say if it's an MCI type of situation, then we would have to start triaging, which we're going to talk about in the next lecture. En route to the scene, easily the most dangerous phase for EMTs. Ambulance crashes cause many serious and sometimes fatal injuries, so we want to make sure that we protect ourselves. Of course, our number one consideration for any call, any situation, any patient always is our safety, personal safety first, and the safety of our partner. And part of that goes into fastening our seatbelts, shoulder harnesses, making sure that we have taken the appropriate steps to secure ourselves within the ambulance before we start responding. Here's also a time that we can review our dispatch information. This is really important for the primary patient caregiver. Usually is not the person driving. So the provider that's driving the ambulance, of course, has a big responsibility in getting us to the scene safely. The primary patient caregiver at this time can use that dispatch information and start preparing for the call. Maybe you get a difficulty breathing that comes through on the dispatch information. Okay, of course, remember that dispatch can be wrong sometimes. They're humans just like us, and sometimes they make mistakes. Sometimes you'll get on scene and find a patient that has nothing to do with what the dispatch information was, but most of the time it's pretty relevant, the information you get from dispatch. So maybe it comes through as a 10-year-old kid with difficulty breathing. As the primary patient caregiver, as we're responding to the call, I'm going to take that time to help my partner navigate, and at the same time I'm running through my protocols. I'm running through what drugs I might have to use. I'm running through in my head different presentations of the patient. If I see the patient in this condition, what algorithm am I going to go down? What treatment pathway? What protocol am I going to use? What drugs might I use? Refreshing myself really quick on the drugs that I might use for that patient and the dosages. And of course, prepare to assess and care for the patient like I talked about. Arrival at the scene, we're going to perform a scene size up and report our findings back to dispatch. We're going to look for any safety hazards. Of course, if the scene is not safe, we do not enter the scene. We radio dispatch and request the appropriate resources to make that scene safe. Evaluate the need for any additional units. Of course, that's going to come from, if you're looking at the trauma and medical assessment, will come from requesting additional EMS, okay, and largely that will be dictated by gather the number of patients, which is also a part of the scene size up. Determine the mechanism of injury or nature of illness. Evaluate the need for spinal immobilization and follow standard precautions. Evaluate the need for spinal immobilization is incredibly important, especially when we start talking about the use of opening the airway, use of the jaw thrust maneuver. Like we've been teaching you up until this point, the indication to use the jaw thrust is based on suspicion of spinal trauma. Notice how I didn't say definitive spinal trauma. Beyond the shadow of a doubt, we know that there is a spinal injury. No, we just need the suspicion of spinal trauma, and that suspicion is largely going to come from the severity of the MOI. MCIs, mass casualty incidents. Like I said, the definition, we're going to talk a lot more in detail about mass casualty incidents in the next lecture. But these mass casualty incidents are defined as 3 or more patients in the book, but a more broad, better definition for MCIs is anything that outnumbers your immediate resources. So if you have to enact an MCI, we're going to estimate and communicate the number of patients with the incident commander. Of course, as you can guess, the incident commander is the person that is in charge, the overseer of the entire incident, and makes the big decisions, really, that we don't have the training to make. Usually on a smaller scale incident, the incident commander is going to be maybe a captain that's on a specific fire engine or on a specific crew, or it might even be the battalion chief or the chief of the entire fire department or the chief of the police force. That all depends on what type of incident it is. Request additional units through dispatch. Remember, dispatch is our lifeline. This is who we contact to get any sort of additional resource. And this might not even be just calling for additional resources such as ambulances. This might be some sort of situation where you get on scene and a fire broke out, or you notice that there's hazardous materials, right? We might need to radio dispatch and ask them for those appropriate resources, law enforcement, fire department, or hazmat crew. Okay, and the incident command system will be established. Again, we're going to talk about that in the next lecture in detail. Safe parking, allow efficient traffic flow and control around an emergency scene. Park at least 100 feet before or past the crash scene. Do not park alongside the crash scene. Park uphill, upwind of hazardous materials. You really want to make a note of that. Registry really likes to ask questions about where you should stage at an incident, or where you should stage at a hazmat incident, or where you should stage really at any call where you think might be a dangerous situation or the scene is not safe. We always want to park uphill, upwind, and the reasoning behind that is if it's airborne pathogens, or it's noxious fumes, or different types of airborne substances, if we park upwind, that means that those particles or those contaminants are going to be blown away from us, not towards us. And of course, if we're dealing with a liquid substance, hazardous material, if we park uphill, that liquid is not going to roll uphill against gravity towards us, right? So it's taking 2 precautions to protect us from the 2 most common types of hazardous material, either airborne or liquid. We're going to leave our warning lights or devices on. Okay. Generally, when we park, we're not going to have the sirens on, but we could have the warning lights on to tell people that we're there, and also give a location to additional arriving units so they can clearly see where we are, and approach the scene from the safest possible route. And keep a safe distance between the emergency vehicle and operations. This slide gives a good visual representation to the point that was made in the last slide, park 100 feet before or after the crash site. So on this picture you can see very clearly the crash site itself with the crumpled up car there in the middle. You can see some road flares or cones that have been placed to kind of direct traffic away from that incident site. You can also see the direction of traffic dictated by that arrow there on the bottom. So this is generally how it's going to work in the field. You can see us parked 100 feet after, if we are in the box truck ambulance that you can see there, 100 feet after the crash site. And in front there, parked diagonally 100 feet before the crash site, is a fire engine. Of course, fire engines are much, much larger than the ambulance, and they weigh a ton. So it's beneficial to have that fire engine that's staged there 100 feet before the crash site as sort of protection if any cars aren't paying attention, or they are going too fast and they swerve into where the crash site would be, where the providers would be, then we have that huge, very heavy, very stable engine blocking the way and it would be much better for a car going very quickly to smash into the side of that engine than to run through the crash scene itself, potentially injuring or killing the patients or the providers that are there on scene. Also, safe parking, we're going to stay away from fires, explosive hazards, downed wires, and unstable structures. The book tells us to use the rule of thumb, quote unquote. And the rule of thumb is you should be standing far enough away and have your arm outstretched with your thumb up. Okay, and with one eye closed, you should be able to cover the entirety of the scene with your thumb. That means that you are a safe distance away. We're going to set the parking brake to make sure that the ambulance doesn't roll, okay, or move while we're not in it. We're going to facilitate emergency medical care and rapid transportation from the scene. And if it is necessary to block traffic, work quickly and safely. This is really where law enforcement comes into play. They're not going to offer much in the way of extrication or medical care, but what the police department is really good at with crash scenes is to set up those road flares, to divert traffic, to really be the eyes in the back of our heads when we have our attention focused on the patient and extrication. The police department is going to play a huge role in helping keep us safe by traffic control and crowd control. Traffic control, provide care and ensure scene safety first. Traffic control is intended to ensure orderly traffic flow, warn other drivers, and prevent another crash, which is a very big possibility when you're dealing with a crash, especially if you're on a highway or in an intersection. Of course, highways and intersections have a very high accident rate, or accident potential, I should say, even if there's not already an accident on the road. So if there is, of course, that just raises the level of intensity in making sure that we're safe and making sure that traffic is diverted away from the scene so that we can work quickly, work safely, and get everybody out of the road as soon as possible. Transfer phase. The patient must be packaged for transport. You see in this picture a patient that's being secured to the gurney by seat belts. Okay, so the two big things required by law for transportation of a patient to the hospital is that they have to be on the gurney secured by these seat belts, and then, like I mentioned earlier, the gurney has to go into the back of the ambulance and actually attach itself to the floor of the ambulance, lock into the floor of the ambulance. Okay. So either we secure the patient to a long backboard for spinal immobilization, the scoop stretcher, or just the gurney itself, like you see in this picture. We're going to lift the patient into the compartment. We're going to secure the patient with straps, and of course we're going to lock the gurney into the floor of the ambulance. When you are ready to leave with the patient, inform dispatch of the number of patients, the name of the receiving hospital, and the beginning mileage of the ambulance. This information will be given to you by the company that you work for. When I got hired for AMR, we had to go through preliminary orientation training where they went over this information with us. And it's really quite simple once you get the hang of it. Dispatch just wants to know where you are. They want to know what you're doing and what the situation is really on the scene because they're not there and they can't see. And also for monitoring of miles, tracking miles of the ambulance, tracking you, making sure that you end up where you're supposed to be, or just in general knowing where you are. So an example of this is every time you need to use radio communication, it's always, hey you, it's me. So you address who you are talking to and make yourself known who you are. So I might say, dispatch, this is AMR 114. We are transporting one patient to Banner Desert, beginning miles of 0.0. Okay, and dispatch will come back and they will copy that information or give you any additional information. And the beginning miles usually are always 0.0 because they're going to track how many miles you drive from the scene to the hospital. We're going to monitor the patient's condition and route. Of course, like you know, we've been talking about it for the entire program. We're going to recheck or reassess a stable patient every 15 minutes. And we're going to reassess an unstable patient every 5 minutes. Okay, we're going to contact the receiving hospital. This is really the job of the primary patient caregiver as we're getting close to the hospital or as we're leaving the scene. And this is called a courtesy notification. This is telling the hospital what kind of patient you have, a really brief introduction to what interventions you've provided to the patient, what assessment findings, pertinent assessment findings you found on the patient, and most importantly, how far away from the hospital you are. And this is important because it not only gives them an ETA or what kind of patient you're bringing in, but allows you to call different alerts like STEMI alerts for heart attacks or stroke alerts, of course, for stroke patients, and giving them an ETA of 10 minutes, 7 minutes, 15 minutes, whatever it might be. It allows the hospital to prepare a room for you, and it also, if it's a significant emergency for the patient, it allows you to it allows the hospital to get a rapid response team down if they need to, a trauma team down if they need to, a neurologist, a trauma physician, a cardiologist if needed. And we're not going to abandon the patient emotionally. Okay, we're going to be aware of the patient's level of need. The delivery phase, notify dispatch of your arrival at the hospital. Again, it's hey you, it's me. Okay, dispatch, this is AMR 114 or Rescue 1, whatever ambulance you might be on or whatever your call sign is. We have arrived on scene at Banner Desert, ending miles 14. Okay. Report your arrival to the triage nurse or other arrival personnel. Okay, this is of course letting them know that you're actually here. So that the patient they've been preparing for, the room that they've prepared for you, you can actually move your patient into that room at this time. Physically transfer the patient. We're going to present a complete verbal report. This is legally one of the things that has to happen when you hand over your patient to another provider, and it needs to be documented completely on the PCR. Complete a detailed patient care report and restock any items at the hospital if possible. En route back to the station, inform dispatch whether you are going back in service and where you are going. Okay, back at the station, clean and disinfect the ambulance and equipment. You want to make sure that the ambulance is clean for the next patient to prevent the spread of diseases or pathogens between patients that you might have on the ambulance, and most importantly, to prevent the spread of disease on the ambulance to us or other providers, because of course we're going to spend a majority of time on that ambulance, so we want to make sure that it's clean. And of course we need to restock supplies. If you are low on supplies or out of supplies, you don't want to take a gamble and just say let's clear and start running calls again. Hopefully we don't get any calls where we have to use that equipment. So the mantra in the field is better safe than sorry. You want to make sure that you have appropriate levels of your supplies before running any calls. The post-run phase, we're going to complete and file any additional written reports. We're going to inform dispatch again of our status, location, and availability. Perform routine inspections. Refuel the vehicle if needed. Usually one full tank of fuel is going to last us for the entire day unless you run an abnormal amount of calls or you are driving all over the place for any number of calls that you might have. So usually one tank of gas will last you for the entire day, but if you need to, again, better safe than sorry. You want to make sure that you tell dispatch that you need to refuel the truck or you need to refuel the ambulance before you start running any more calls. Some key terms that you need to be aware of: cleaning, disinfection, high-level disinfection, and sterilization. Cleaning is really what you might do at home, clearing the dust off of your countertops or your tables or anything like that. Just wiping down the surfaces with maybe Windex or Pledge or something like that. And it's really just getting the dust and dirt off of the surfaces in the ambulance. It really doesn't have that much to do with the next one down, which is disinfection. Disinfection is using some sort of chemical agent to actually kill or destroy pathogens that might be on the gurney or the equipment or the surfaces of the ambulance. High-level disinfection just means using very potent chemical agents to kill a wide variety of pathogens and bacteria and viruses. And sterilization is using extreme heat to kill all microbial contaminants at the minuscule level, at the microscopic level. So these terms you need to be familiar with and the differences between them. After each call, we're going to strip all the linens off of the stretcher and place them in a plastic bag or designated receptacle. We're going to discard any medical waste, of course, any bodily fluids, urine, feces, blood, vomit, amniotic fluid, anything like that, human tissue, if needed, needs to go in a biohazard bag. And those are red bags, specially designated with the biohazard symbol, and those need to be disposed of properly. We can't throw those substances just away in just a normal trash can. We're going to wash all contaminated areas with soap and water. Disinfect all non-disposable equipment used for patient care. We're going to disinfect all non-disposable equipment, like I said. This equipment might be the monitor that we use. Of course, we can't throw that away. It's $20,000 a monitor. We're not just going to throw that away. Of course, we need to make sure that we clean it, though, before we apply it or attach it to the next patient. But all of the stuff that is disposable, like gauze pads or even the BVMs, are meant to be disposable. If we use them on a patient, we are going to throw them away. We're not going to keep them around and sterilize them. But the monitor is the prime example of a non-disposable piece of equipment that we need to disinfect before the next patient contact. We can clean the stretcher with a germicidal or virucidal solution or a 1 to 100 bleach dilution, which is 1 part bleach, 100 parts water. You want to make sure that you do this correctly. You want to make sure that you don't do 1 to 10 bleach dilution, because that is extremely potent with bleach. You want to make sure you don't do any skin damage to yourself or breathing those fumes that come off of a bleach solution. In the hospital, you might have noticed, if you have done your clinicals, you might have noticed what I call the purple tops, the canisters that contain the wipes that you use to wipe down the equipment and wipe down the hospital beds. That's called Cavicide, which is an extremely potent germicidal or virucidal solution, and it destroys just about anything you can think of when it dries, including your skin. It is a proven carcinogen, and it can actually give you cancer. That's why there's a huge precaution on using those purple tops to make sure that you have gloves on. And we're going to clean any spillage or other contaminants with one of these same solutions. Create a schedule for routine full cleaning of the emergency vehicle, and create a written policy or procedure for the cleaning of each piece of equipment. Usually this is going to be done for you by your supervisors or by your field training officers. You might be enlisted to help with this, but in my experience, usually this is done before any employees are brought on or new hires are brought on. Defensive ambulance driving techniques. An ambulance involved in a crash delays patient care and may take the lives of EMTs, other motorists, or pedestrians, and your patient. So like I said, being an EMT, if you're running on an EMT and a medic crew, just because the medic's in the back does not make your job important. As a paramedic, I am fully entrusting my life in your hands if you're driving the ambulance. I need to make sure that you are on the top of your game in terms of you're paying attention, you are a good defensive driver, that you're not fatigued, that you're not distracted by cell phones or music or eating or anything like that, or even the GPS that's on the ambulance. As the EMT, most of the time you're going to be driving, which means that you need to be doing so appropriately, because if you If you are not, it could very well mean that the patient, yourself, and me could all die or become very seriously injured. So driver characteristics, some states require an emergency vehicle operator's course, or EVOC. Again, this should be handled by your company. It is required in the state of Arizona. It should be handled by your company when you are hired, usually when you go through your new hire orientation. Other characteristics, physical fitness and alertness, emotional maturity and stability, and the ability to act with due regard for the safety of others and the preservation of property. Safe driving practices. Speed does not save lives, good care does. This is one of the best points in the entire lecture. There was a huge study that was done across the country, and they determined that driving full Code 3 lights and sirens on average saves you about 30 seconds of transport time, as opposed to driving normally without lights and sirens. And on top of that, it increases your chances of a fatal ambulance crash by 90%. So realize that you speeding down the road or blowing through stop signs or through red lights is not going to save a patient's life. The quality of the care that we give them is going to play a much bigger role in that. We're going to keep ourselves safe by making sure that we wear our seatbelts anytime the ambulance is in motion. We're going to become familiar with how the vehicle accelerates, corners, sways, and stops. If all you've ever driven your whole life is a smaller vehicle, and you haven't had the chance to drive maybe, say, a 12 or 15 passenger van, or maybe a Suburban would help a little bit. Bigger vehicles like that, if you have some experience, it's pretty similar to how an ambulance operates. Of course, an ambulance is incredibly heavy, which means that it takes more time to accelerate and takes more time to brake. And of course, with the high center of gravity for SUVs and especially ambulances, they are prone to rollovers. If they get hit in the right spot or with enough force, it could tip the ambulance onto its side. We're going to stay in the extreme left-hand lane on multi-lane highways. Siren risk-benefit analysis. The decision to activate the emergency lights and sirens will depend on your local protocols, the patient's condition. Of course, we're not going to go Code 3 for a stable patient. We're not going to go Code 3 for a patient that's not experiencing a true emergency. And of course, that plays into the anticipated clinical outcome of the patient. Driver anticipation. Always assume the motorists around your vehicle have not heard your siren or public address system or have seen you at all. I specifically remember when my dad was teaching me how to drive, he made a very clear point to say, when you're driving, you almost have to assume that you are the only person on the road that knows how to operate this car appropriately. And that stuck with me throughout my whole driving career, and especially when I was operating the ambulance. You kind of have to have eyes in the back and in the side of your head, so to speak. Keep your head on a swivel, which means that you are continuously evaluating the road as you're driving and making sure that you are avoiding any threats, because you can't assume that the motorists around you are going to be operating their vehicles safely or with due regard. The cushion of safety, I'm sure you've heard before if you have your driver's license. What the cushion of safety is giving you enough space between yourself and the car in front of you that if they stop abruptly, you have enough time to decelerate the ambulance. Like we talked about, ambulances are so heavy that it takes more stopping power and it takes more time to bring that ambulance to rest. So you don't want to be tailgating the car in front of you. You want to make sure that you have an appropriate amount of space. Ensure that the blind spots do not prevent you from seeing vehicles or pedestrians. Never get out of the ambulance to confront a driver. Be aware of blind spots and scan your mirrors frequently. Excessive speed, if necessary, is unnecessary, is dangerous, and does not increase the patient's chance of survival. It only increases your chances of being in a serious or fatal accident. It makes it difficult to provide care in the patient compartment. I can attest to this as a paramedic. I spend all my time in the back of the ambulance. And you can really easily tell the difference between trying to place an IV while you're bumping down the road at 45 miles an hour as opposed to 60 miles an hour as opposed to 70 miles an hour. It makes it a lot more difficult and dangerous to provide medical care in the back of the ambulance at a high rate of speed. It also hinders your reaction time. If you're driving really fast on the road and somebody does something unexpected like swerves into your lane or makes an abrupt stop, the faster you're driving, the less time you have to react safely. And of course, increases the time and distance needed to stop the ambulance. Siren syndrome causes drivers to drive faster in the presence of sirens due to increased anxiety. This doesn't just happen to people around us, but it happens to us, the people that are actually driving the ambulance. Of course, when you go full lights and sirens, you're going to have a rush of adrenaline. You're going to start to feel that sympathetic nervous system kick in, and you start to get hyped up and jazzed up, and all of a sudden you know you're going 10 miles an hour faster than you should be. So if it's a problem for us, we can of course assume that it's going to be a problem for other motorists around us. Vehicle size and distance judgment. Crashes often occur when the vehicle is backing up, so use a spotter. A lot of departments and ambulance companies have gotten really strict about using a spotter every single time you have to back up the ambulance. Even if you think you're okay, make sure that you use a spotter. The reason that they're cracking down is there was a red shirt that worked for Phoenix Fire a couple of years ago, and somebody was backing up the ambulance and or the fire engine and was not using a spotter, and tragically crushed this young man between the apparatus and a post or a wall or something like that, and ended up killing him. So that was an unnecessary loss of a provider, and it's very sad. So from now, like I said, all these departments are cracking down on the use of a spotter, and it's just someone that's standing in the back of the ambulance that's giving you directions and making sure that nothing is in your way as you are backing up. And of course, the size and weight of the ambulance influences braking and stopping times. Road positioning and cornering to keep the ambulance in the proper lane when turning. Enter high in the lane and exit low. If you turn too early or too late, you could end up not having enough turning distance and end up running into a wall or onto the curb or something like that. So we want to make sure that we are turning appropriately at the right time when approaching a turn, to make sure that we have enough space to turn and that we don't injure any persons or property. Weather and road conditions. Ambulances have longer braking times and stopping distances. The weight of the ambulance is unevenly distributed, which makes it more prone to a rollover. Like I talked about, this is due to the ambulance's high center of gravity. Like any SUV or larger vehicle, that high center of gravity makes it more prone to rollovers if it gets the right amount of force in exactly the right position. Be alert for hydroplaning, which is you could be driving at just a fast enough rate of speed and you hit a big enough freestanding pool of water or puddle of water that instead of gripping the actual road, the wheel of the ambulance is actually sliding over the surface of the water, which of course causes you to lose traction, causes you to lose control of the ambulance, and greatly increases your chances of a crash. And one of the things that registry wants you to know, or what's in the book, I've seen questions about it, is that the ambulance can start hydroplating at speeds as low as 30 miles an hour. Of course, we want to watch out for any water on the roadway, decreased visibility, and ice and slippery surfaces that might cause the ambulance to lose traction and cause you to lose control. Laws and regulations. If you are on an emergency call and are using your warning lights and sirens, you may be allowed to do the following: park or stand in an illegal location, proceed through a red light or a stop sign, drive faster than the speed limit, drive against the flow of traffic, and travel left of center to make an illegal pass. An emergency vehicle is never allowed to pass a school bus that is stopped to load or unload children. So we all know those red stop signs that flip out of the side of a school bus when it's loading or unloading children. And if in any direction you're traveling, if you see those, of course, by law, you have to bring the vehicle to a complete stop. Lights and sirens does not allow you to surpass this law and be able to drive past the school bus with the red stop signs out. So if you are driving code 3 and you end up coming up on a school bus with those stop signs flipped out, you're going to degrade from code 3 to no lights and sirens and bring the ambulance to a complete stop until the bus has finished unloading or loading on children, has put the stop signs back in, and then you can move around the school bus, upgrade to code 3 again, and proceed as you were before. In the use of warning lights and sirens, the unit must be on a true emergency call. You can't super bad the lights and sirens and use them just to get through a stop sign or a red light. We have devices on the ambulance that video and audio record anytime those lights and sirens are activated. They tell you exactly when. It tells your supervisor exactly when the lights and sirens were turned on and for how long of a duration they were used. So to avoid getting in trouble legally and avoid getting in trouble with your company, you might actually get fired for it. You want to make sure that you are only using them sparingly on a true emergency call when it's warranted. Both audible and visual warning devices must be used simultaneously. The only time that we are ever going to have the lights on without the siren is if we are, like we talked about earlier, staged somewhere, parked, where you don't need to have the sirens on, but you might have the warning lights on to, of course, warn maybe other motorists that you're on the roadway, or signal other arriving responders or vehicles of where you're parked or where you're at. But other than that, if we are driving or operating the ambulance, there is never any situation that we would use lights without sirens or sirens without lights. And the unit must be operated with due regard for other safety. Right-of-way privileges. Emergency vehicles have the right to disregard the rules of the road, some rules of the road, when responding to an emergency. This does not give you the permission to drive however you want, wherever you want, whenever you want. You have to still follow the rules of the road, and a lot of those rules at the state level or the company level will be made very clear to you during that emergency vehicle operators course when you get hired with your specific company as you're going through the new hire training or the orientation. Do not endanger people or property under any circumstances, and get to know your local right-of-way privileges. Use of escorts. Use escorts as a guide only when you are in unfamiliar territory. This doesn't happen very often, but if you needed to, then that escort would usually be a police escort by either a squad car or by motorcycle police officers to escort you to the location that you need to get to. Intersection hazards. Intersection crashes are the most common and the most serious. If you cannot wait for traffic lights to change, come to a brief stop and look for pedestrians or other hazards. So what we do when we come up on a intersection, whether the light is red or green, if we're driving code 3, we're going to make a complete stop at the intersection, and your partner that's driving is going to look to one side of the vehicle, and the other partner is going to look to the other side of the vehicle and systematically clear every single lane of traffic, and putting an eye on any cars that might not see that you're going code 3 or that you're going to proceed through the intersection, as well as identifying any other hazards or obstructions in the path of the vehicle as you're driving. Highways. Shut down emergency lights and sirens until you have reached the far left lane. It's never a good idea to use full lights and sirens on the highway because most people understand, even bystanders understand, that if you see emergency lights and sirens, that you're immediately supposed to pull over to the right shoulder of the street or the roadway and come to a complete stop. Of course, this causes a lot of problems with people that are traveling 75, 80, 85 miles an hour on the highway, and they see your lights and sirens and start to slam on their brakes and pull over to the right side of the road. So use very sparingly. On unpaved roads, operate at a lower speed with a firm grip on the steering wheel. And in school zones, even if you are driving code 3, it is unlawful to exceed the speed limit. So it would be good practice to downgrade from code 3 and drive whatever the posted speed limit is for that school zone. And once you've exited the school zone, you are allowed to upgrade to code 3 again and proceed as you were before. Distractions: focus on driving and anticipating roadway hazards. We can minimize distractions from the mobile dispatch terminals or those laptops that are secured in the passenger seat, and the GPS if you're using one to help navigate either to and from the hospital or to and from the station. The mounted mobile radio can cause issues with distraction. Generally, if the ambulance is in motion, the person that should be operating the radio is the person in the driver's seat, especially if you don't have a patient in the back or you're not transporting anybody. The stereo, cell phone, eating and drinking can all cause distractions. Those are all things that we can eliminate while we're driving to make our transport that much safer for ourselves and for the patient. Driving alone, it is your responsibility to focus on figuring out the safest route while mentally preparing for the call. Such situations demand your complete attention and focus. Fatigue: recognize when you are fatigued and alert your partner or supervisor. This is really a double-edged sword because it is your responsibility to make sure that you show up for work every day prepared, which means that you bring any equipment that you might need, that you show up well rested, and that you avoid fatigue. Of course, with long hours and crazy work schedules and the shift before, you might have run 15 calls or something like that, and of course you're tired. But it's worth reporting to the supervisor and avoiding having that fatigue cause a problem like a fatal ambulance crash. So you might get reprimanded, or in a severe situation, you might even get fired for not showing up to work the way that you should be, which is a very minimal cost to pay as opposed to being the one responsible for the death of a patient or the death of your partner. You should be placed out of service for the remainder of the shift or until the fatigue has passed and you feel capable of operating the vehicle safely. Air medical operations. Air ambulances have been used to evacuate medical and trauma patients. We either have fixed wing units or rotary wing units, which are helicopters. An example of the fixed wing unit you can see on that top picture there on the slide. Those are those Learjets or fixed wing aircraft can travel at a much faster rate of speed and usually travel at a much higher altitude than helicopters can. So those are generally used for long-term transport, maybe transcontinental or international transports, whereas the helicopters can't fly as far or as fast, but helicopters are versatile in the sense that they can fly forward, backward, side to side, and they can stop on a dime. They can hover. And helicopters can land pretty much anywhere they want, given enough space. They don't need a runway with adequate stopping distance like the fixed wing helicopters do. Excuse me, the fixed wing planes do. So helicopters are used in a day-to-day respect in medical transportation far more than the fixed wing units are, but they both have their place and they both have their pros and cons. Specially trained crews accompany air ambulance flights. Okay. EMTs are usually providing ground support. Medical evacuation or medevac is performed by helicopters usually. Like I said, on a day-to-day basis, we use these more than the fixed wing airplanes. Why call for medevac? Okay. Transport time by ground might be too long, or the road, traffic, or environmental conditions prohibit the use of ground transport. But as a general principle, if it is too dangerous for you to drive on the ground, maybe due to weather conditions, then it's likely going to be the same case for a helicopter to operate in those same conditions. The patient requires advanced care. Of course, air medical units are generally staffed by flight nurses and flight paramedics, which are ALS, level of training, advanced life support. So if the patient needs to get somewhere quickly, we can use medevac. Or if the patient needs to go a long distance and requires specialty care or advanced care, would be a good indication to use medevac. Multiple patients will overwhelm the resources of the hospital reachable by ground. We might use medevac in a mass casualty incident, maybe where we have a lot of patients and we are sending those critical patients out to the nearest hospitals. Those nearest hospitals, of course, they only have too many resources or beds that are available to take some of those patients. So we might have to use medevac to lift those patients out of the scene and take them to another hospital that's farther away, that might be just too far or take too much time to reach for that critical patient if we took them by ground. Who receives medevac? Patients with a time-dependent illness or injury, patients with a stroke, heart attack, or spinal cord injury, scuba diving accidents, near drownings, or skiing and wilderness accidents. Those remote areas, it's easy for a helicopter to get out there, pick up the patient, and take them to an appropriate facility in a much shorter period of time than it would be to take them by ground. A good example of that is I have a very good friend that works as a paramedic up in Payson, and the only hospital that's really close in Payson is Payson Regional Medical Center, which is a level 4 facility, so they can't really handle really critical patients. So when my friend ends up running a call on a really serious patient, he might make the decision to involve air medical and have a helicopter come and take that patient out. And it would be with traffic anywhere from an hour to an hour and a half, hour 45 minutes to transport a patient from Payson down to a level 1 center that we have here in the valley. And with a helicopter on a clear day, would generally take about 20 minutes. So you can see the advantage there for very critical patients to have them flown rather than driven to their destination. Whom do you call? Generally, the dispatcher should be notified first. This is really how it's going to work for us. If we need to call medevac, we would radio dispatch and request that resource, and they will get a hold of the flight company and the flight crew and get them to start the helicopter, the blades turning, and eventually bring the helicopter out to you. So just like we would request additional resources like law enforcement, police department, hazmat, we would also request this specialty resource through dispatch. Establishing a landing zone, this is important. I've seen registry ask a lot of questions about this. You want to make sure it's a hard or grassy level surface between 60 by 60 feet and 100 by 100 feet. So the minimum is 60 by 60 feet, and the recommended distance for the landing zone is a square of 100 by 100 feet. We want to make sure it's clear of loose debris. I don't know if you've spent a lot of time around helicopters or you've seen what helicopters can do. Once they get close to the ground, they produce a lot of rotor wash or ground wash, air that ends up making its way down to the ground from those rotor blades that are spinning at an incredibly high rate of speed. They can, if there's loose debris or dirt or anything of that sort, of course those rotor blades are going to throw it, which could potentially harm somebody. It could make the scene not safe. It could make landing difficult for the pilot. And in a worst case scenario, big enough pieces of debris can actually cycle back up into the rotor blades and damage them. We want to make sure that the area is clear of overhead or tall hazards. The two biggest ones are large trees and tree branches, and we also want to watch out for any fences in the way, like chain link fences on the ground. We also want to communicate any obstacles to dispatch that will relay that information to the flight crew, the pilot specifically. The biggest one is any power lines or any telephone wires. Those are very important as a pilot. It's really hard to see those, especially at night, so we want to make sure that we do our due diligence and make sure that the pilot knows exactly what kind of situation they're flying into. We can mark the landing site using cones or vehicles. Never use caution tape or people to mark the site, and do not use flares. Never point any bright lights up in the air towards the helicopter, because all you're going to do is end up blinding the pilot and they're not going to be able to see where they're going. So if you're going to use lights to mark the landing zone, make sure that they're pointed down at the ground. One of my favorite things to do is to set up 4 vehicles, 4 ambulances, whatever the situation might be, whatever resources you might have at the corners of the 60 by 60 or 100 by 100 foot landing zone, with the headlights pointed inward, which makes a nice lighted X towards the middle of the landing zone, so the pilot knows exactly the best place to land. Move non-essential persons and vehicles out of the landing zone. We want to make that as clear of a spot as possible for these helicopters to land. And we're going to communicate the direction of any strong wind to the flight crew. Landing zone safety and patient transfer. Keep a safe distance from the aircraft whenever it is on the ground and hot. So we have different loads, which means loading the patient into the helicopter. A hot load would mean that we are putting the patient into the helicopter while the blades are still turning, while the helicopter is still on. And a cold load, of course, would be we're loading the patient into the helicopter while the blades are not turning, while they're not spinning. So in any case, either a hot or a cold load, you don't want to make any assumptions about the helicopter and do anything brash or anything that might cause danger to the crew or yourself. One of the #1 rules of dealing with a helicopter or being around a helicopter is never, ever, 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 ever times infinity approach the tail rotor. The tail rotor blades are much shorter than the main rotor blades, and the tail rotor blades at night can spin so fast, even during the daytime, it makes them difficult to see. You might not even be able to see them. And of course, if one of those gets a hold of you, it almost guarantees your death. So you want to make sure that you stay away from the tail rotor. And another good safety rule for helicopters is always approach the helicopter from the front. More importantly, always make sure that you are in the line of sight of the pilot, or at the very least the helicopter crew. So don't approach the helicopter without gaining permission from the flight crew. And if you're not sure about what to do, ask the flight crew. They'll be able to tell you what you should do, what you shouldn't do, and they'll walk you through the steps and make sure that everybody's safe. Like you can see on this slide right here, the main rotor blades of a helicopter can dip as low as 4 feet off the ground. Very rarely does this happen, but it is a capability. So it's kind of common practice, no matter how tall the helicopter is, to approach the helicopter with either your head ducked or kind of in a crouching position. You don't have to army crawl over to the helicopter by any means, but even on these larger helicopters, it's not that much of a risk. But on the smaller helicopters, their rotor blades, while they're spinning, might be anywhere from 6 or 7 feet. So you kind of want to take that precaution and make sure that you understand that the main rotor blades can get that low. Of course, do not approach the helicopter from the tail end. Don't go anywhere near the tail section of the helicopter. Keep the following guidelines in mind. Become familiar with hand signals. Do not approach the helicopter unless instructed and accompanied by the flight crew. Make sure that all equipment and the patient are secured to the stretcher. You don't want any hats or any blankets or pieces of equipment flying off of the gurney as you approach the helicopter. Smoking, open lights or flames, and flares are prohibited within 50 feet of the helicopter. And it would be a safe practice. It's not necessary to consider eye protection, especially if you're in a place where the rotor blades are throwing dust around or debris or anything like that. And here you see, you don't have to know these explicitly, but here you see some directional motions that you can make to help guide the pilot to land on land in the landing zone appropriately. Kind of some directional terms, almost as if you were spotting an ambulance, and where to park or where to back up or where to drive. It's kind of the same thing. You aren't required to know these, but on a beneficial level, you could know these or understand these for use out in the field if you were to ever utilize a helicopter for transportation. Special considerations: night landings, do not shine spotlights, flashlights, or any other lights in the air to help the pilot. Direct low intensity headlights or lanterns toward the ground, like we talked about. Illuminate any overhead hazards or obstructions if possible, like we talked about, tall trees or power lines, but don't shine it directly up from the landing zone or at the helicopter itself. As you can see on this slide, landing on uneven ground, helicopters can actually make what's called a slope landing, which means, like you see in the picture, they're landing on a slope gradient of the ground. Helicopters can do this, but of course, when the helicopter is sitting on a slope gradient, the upslope, if you were to approach from that area where you see marked on this slide as the danger area with those red lines, the rotor blade is going to be closer to the ground on the uphill side. So you always want to approach the helicopter from the downhill side if they are landing on a slope, because that gives you more room, more space between the ground and the main rotor blade. Medevac at hazardous materials incident, notify the flight crew ahead of time that they're not just responding to some sort of vehicle accident or some other run-of-the-mill call, that they are actually approaching a hazmat incident. Consult somebody beneficially, could be the hazmat crew that's on scene. If they're already on scene, you can consult them about the best way to approach the scene and the distance from the scene that the helicopter should be. The landing zone should be, again, like our ambulance for any hazardous material incident, uphill and upwind. Let that stick in your mind. Eat, sleep, and breathe uphill, upwind. There's a good potential that you're going to see questions about that from registry. And of course, we want to decontaminate patients before loading them into the helicopter. A lot of patients wear, like anybody else, cotton-based clothing, and cotton is very porous, and it can hold on to certain things like cyanide or noxious fumes or carbon monoxide inside of the cotton. So think about if we were to put that patient that hasn't been decontaminated or their clothes haven't been taken off, and we put them inside of the helicopter, very closed, very tight space that is poorly ventilated. Now that patient's going to start off-gassing that chemical, and not only the providers will be affected, but more importantly, the pilot could start to become affected. And of course, mid-flight in a helicopter, if the pilot starts to lose consciousness, you can guess the outcome. So we definitely want to make sure that even on the ambulance, before we transport somebody that's been in a hazmat incident, that they are appropriately decontaminated and their contaminated clothes are removed. We need to put a priority on that, especially for helicopters as well. Medevac issues. Assess the severity of the weather or the environment or terrain. Most helicopters are limited to flying at or around 10,000 feet above sea level. and medevac helicopters can fly anywhere between 130 and 150 miles an hour. Believe me, when you're up in a helicopter, it doesn't seem like you're going that fast at that height. Even at 2,000 feet above the ground, it seems like you're barely crawling along. But the lower you get to the ground, you start to realize the magnitude of how fast you're actually traveling. Because of the cabin's confined space, assess the number and the size of the patients who can be safely transported in a medevac helicopter. Typical medevac flights are extremely expensive compared to ambulance transport, so I'm going to make a point about this first bullet and then the second bullet. So helicopters have what's called a max gross weight, which means that every pound of weight that is on the helicopter has to add up to a total that is less than the helicopter's max gross weight. It's a preset number that the manufacturer of the helicopter has figured out and put together and advised the pilot and the flight crew will know about this max gross weight. But it's important for them to keep that in mind because the pilot and the two providers, their weight, plus all the medical equipment, plus the helicopter itself, plus the fuel, plus the patient now that's going to be added to the helicopter, all of that weight has to be below the max gross weight. If you are at or above a helicopter's max gross weight, the helicopter won't even take off from the ground. So we need to inform the flight crew about the number and the size of the patient that is going to be transported in the helicopter. And about the second bullet point, we talked about a while ago being a patient advocate, which means standing up for your patient no matter what the situation is, and being an advocate for them, not only through your transport or your care. We also need to be a patient advocate that we're not, in the sense that we're not running up a medical bill on them unnecessarily. You have to understand that without transport or without any interventions or medical care, to get the blades turning on a helicopter for a medevac transport is about 15 grand, or depending on the company, really anywhere between 15 and 20 grand. So you don't want to stick a patient with that kind of bill if they don't absolutely need it. So take caution in the sense that you are using medevac appropriately for your patient, but because it's going to cost them so much money if you don't. And you also want to make sure that you don't let that deter you from actually utilizing medevac for somebody that really truly could benefit or does need that medevac flight. So this concludes the transport operations lecture. I hope you guys enjoyed. As always, we're not going to go through I'm not going to go through the review questions at the end of the slide at the end of this lecture, but I highly encourage you to do so. And keep studying, and I'll see you in the next lecture.